We'd love to.
Yeah,
We're building out a whole series around from everything from medical to adult use. So there is plenty of space for additional conversations, and we would hope that you would lean on us as a partner in being able to disseminate that information.
definitely.
We have another minute, so whatever you need, you got a second to get what you need, water.
Don't tell me twice.
You got a few minutes to get some water, go to the
Really?
bathroom.
I got a minute for water? Okay, I'm gonna get it.
Please do. Yes, you got time. Yeah, guys, we could give them, you could extend this out, their presentations, because you've got time to be able to do that, to have them dig in a little deeper.
I didn't realize that we had the Zoom backgrounds as default. Oh, sorry, to make sure. There we go. I didn't realize that we had these as default. I thought you guys were both uploading it yourself. So just change your background. I just
Uh,
learned something new.
Yeah. Oh, one thing I was thinking for the polls, once we let them in, I think maybe it'll be helpful if we just go ahead and start the polls, and maybe W will say, like, as you guys, let's give a few minutes to come in.
Yes.
Poll is coming up. So that way, like, it'll help with like the
Yep. All right, guys,
out the way.
12:01. So need to start letting folks in.
Got it. But one thing about the poll, we have to wait till a couple of people come in first, because if you come in after the poll starts, you can't see it. But I'll start letting.
Oh, I didn't know that. Okay. Learn something new. Script. Let me get some chat stuff.
Good afternoon, everyone. My name is Deborah Levine, and I am the Community Engagement Officer for the City University, the Graduate School of Public Health and Health Policy. Welcome today to Breaking Barriers Through Leadership, Leading with Justice, Part 3. Today, we have a fabulous presentation from the Office of Cannabis Management, and we're super excited, as you can see from our agenda. This is going to be a really exciting and detailed conversation. First, I'd like to take the opportunity to thank our partners, Community Board 9 in Manhattan, Community Board 10, Just Us Foundation, Youth Connect, and the Manhattan EOC. So thank you for partnering with us on this really important conversation. Just some housekeeping as we move forward. Next slide. So for today's webinar, we'll be using the Q&A function at the bottom of your screen. In order to put a question in, you'll see if you move your indicator to your toolbar at the bottom, you'll see that there's a Q&A button. If you don't see it, please feel free to move over to the More button, which is on the right-hand side. Hover over that, click it, and you'll see that there'll be a pop-up menu that says Q&A. Type your question in the box, and you can hit that either as anonymous, or you can tell us who you are. When the question comes up, the host will read your question out as our presenters respond to those questions. You'll also see that there is a poll that has come up, and as always, we'd like to know how you learned about this webinar so that we know how our partners are helping us to be able to get this information out and how we can do better at disseminating the information. Also, it gives us some insight a little bit about who you are and how we can better serve you. So please, if you would take a few minutes, the poll is only 3 questions. And so we're super excited to get this started. We'll give a few more minutes for people to join us. Next slide, as people are filling out. So I would like to also let you know that this webinar, along with our other webinar series, will also be available for continuing education for community health workers. And there'll be more details about how to get those continuing educations at the end of this webinar series, along with additional information about the Office of how you can work with us to partner on future events. So we'll just ask that a few more people continue to fill out the poll. And so it gives me great pleasure to introduce our moderator for today's webinar. Tanisha Hicks is a master's in public health and a graduate of the Graduate School of Public Health and Health Policy, and is also our school's cannabis equity coordinator. And so we are super excited to have her facilitate today. So I will decrease and be hanging out in the background as she begins to introduce this panel and move us through the process. Thank you again on behalf of the Dean, Dr. Ayman El-Mohandes, his team, and the faculty here at the School of Public Health. Enjoy your webinar.
Good afternoon, everyone. Thank you, Deborah, for that incredible introduction. So without further ado, any rambling from us, I want to introduce our first speaker, Tabitha Robinson. She is the New York State OCM's Director of Economic Development, Policy and Research Team. Today, she will present on the potential of the medical cannabis program to address healthcare equity and expand access to medical treatment. In addition, she will also discuss the healthcare disparities and their impact on underserved communities, and also some strategies that ensure equitable healthcare access for marginalized communities. So it's an honor for me today to introduce Tabitha Robinson.
Hi, everyone. Good morning. It's a true pleasure to be here. Thank you for hosting us, and thank you for taking the time to have us here today. I am the Director of Economic Development, Policy and Research at OCM. My position sits on the Social and Economic Equity Team, which is overseen by our Chief Equity Officer, Damien Fagan. For the record, I am not a medical professional, and my background is not in medical policy. I am, however, on the Health Equity Team, which is a working group within the agency comprised of individuals who do have that health, medicinal, clinical background, and individuals who have a more social equity background. Today, I'm going to talk to you a bit about the medical program, where it's been, where it's going, but specifically with the lens of health equity. So what does it mean to have a medical program? I think oftentimes here in New York, with the legalization of adult use or recreational cannabis in 2021, that program tends to get a lot more of the attention. The medical program is often deprioritized in public discourse, but it is the founding program of cannabis legalization in the state. In 2015, the Department of Health began the process of licensing medical cannabis operators in the state of New York. And I'm sure you can imagine at that time, we were still deep in prohibition. This is before the decriminalization that came around with 3 ounces and so forth. So it was a very risky move at that time. And the medical program has been in full swing since then, with the first set of operators being chosen in 2015. At that time, the legislation that oversaw the program was the Compassionate Care Act, or the CCC. When adult use legalized in 2021 under the cannabis law, in an act known as the MRTA, or Marijuana Regulation and Taxation Act, that same act also took the program from the Department of Health and brought it to the Office of Cannabis Management. The MRTA also superseded the Compassionate Care Act. And so now we're living in a world where both medical and adult use are housed in the MRTA and are housed by OCM. So what does it mean to have a medical program, especially a medical program that runs alongside the adult use program, which was just recently launched? One, we have to make sure that this program doesn't die. We have to make sure that the medical program continues on, that it doesn't become eclipsed or cannibalized by adult use. Two, we need to make sure that patients are still identifying themselves as patients. We recognize that a lot of cannabis users actually use it for medicinal purposes. Despite the fact that public discourse thinks about cannabis users having fun and getting high, drinking alcohol, in the same way that many pharmaceutical drugs have alcohol within them, we think about cannabis being the same way. Yes, there's a recreational use, but there's also very much a medicinal use. And we want to make sure that patients are still raising their hands and identifying themselves as patients with a medical need, that they're still seeking out that medical permission in order to use the substance and use it to treat their ailments. So what have we done since the program came over from DOH? We've done a number of things. For one, we've expanded the list of qualifying conditions for patients. So previously, the list was less than 50 conditions that would enable you to go to a doctor and request to use cannabis for medical purposes. We've expanded that list. Secondly, we have expanded the types of practitioners that can certify these patients. Again, when it was first legalized, the state was in a much different position in terms of risk assessment. And the risk at that point was seen as too great to allow just any old body, as they say, to certify patients. Now, we've expanded it, and by expanding the type of practitioners that could certify patients, we've been able to expand the number of practitioners. So now there are about 4,200 practitioners around the state who can certify patients. Now, it's important to recognize that that certification is not the same thing as a prescription. Because cannabis is federally illegal, although legal in the state of New York, there's this weird sort of legal discourse that happens. In order to not violate federal statute and the federal illegality of it, it cannot technically be a prescription, according to the FDA. It can, however, be a recommendation or a certification. So that's the language that we use. And these practitioners are able to certify patients. We have about 119,000 registered patients in the state of New York who are receiving their product. They go to these medical dispensaries around the state, and these medical dispensaries are able to provide them with on-site assistance and care from pharmacists and other public health related professionals who can direct them towards certain products. This all occurs in a tax-free way, and that's part of the benefit that many of our patients see in identifying themselves as patients and going through the certification process, is that it is a cheaper product for them. Now, is the cannabis different from the recreational? Generally, no. However, there are certain strains that have been developed specifically for medical treatment. For example, we know that a lot of our patients are undergoing chemotherapy or have some cancer treatment related side effects. And there are specific strains that medical professionals tend to direct them to in order to address that. So how do we make sure that health equity is at the forefront of this? First and foremost, we see our responsibility as education. right? Educating the public about this program, about the benefits of identifying themselves as patients, going through the process of becoming a certified patient and continuing on this track. And that education needs to happen, especially within our marginalized communities. One of the benefits of starting the industry with this medical program is that it's a way to, it has served as a way unintentionally, but to combat the stigma that's often associated with cannabis use, right? And so we see our role as educating the public, and especially within marginalized communities, as again, helping them to realize that cannabis is medicine. Additionally, we are increasing the number of trainings that we're doing, making sure that the practitioners who are certified with the state don't just get their certification license once and finish. In order to be certified as a practitioner, you have to go through a course at OCM, and there's information on our website. And after that course, they fill out a certificate and they're certified to provide cannabis recommendations to patients. We want to make sure that that is not the only touch point that these practitioners have with the Office of Cannabis Management, and that is not the only time that we are checking in with them. We are rolling out very soon programming to continue training these trainers, and we're working with vendors. We're working with a vendor that consists of academic institutions and advocates who work in this space and are dedicated to the space nationwide. This work is obviously ongoing, but again, it is a way for us to make sure that our practitioners are current with what's happening in the space, that they are trained on addressing their own biases. Part of the training is around diversity, equity, and inclusion work, right? We want to make sure that the biases that have existed, especially during prohibition and criminalization, are not then being brought to the forefront of the medical program. It is a challenge within government, as many things are, because of the amount of red tape and bureaucracy that as a government agency we have to go through. So as we form these partnerships, we are trying to be very sensitive of the limitations that we have in terms of not partnering, for example, with anyone that has an interest in a cannabis license or in a cannabis business. Another thing I'll touch on before passing it to my colleague is the expansion of our program vis-a-vis operators and vis-a-vis communities. We have been able to identify communities around the state that are unserved and underserved areas of the state. I'm gonna ask Priya to please share the second link I provided. It should say cannabis.ny.gov, unserved and underserved. And I'll just walk you all through this site and a bit about how it touches on healthcare equity. Right.
Do you want us to bring up the site?
Yes, please. Okay, great. So this page here is our unserved and underserved areas of New York State. In the when the medical program moves from the Compassionate Care Act over to the MRTA, the MRTA essentially added on a health equity layer. Now that term health equity doesn't actually exist in statute, but we use it internally to describe the ethos and the spirit of what we see in the law. The law has specific criteria, for example, when it talks about the ways in which our registered organizations, which I'll touch on in a bit, but those are medical operators, the ways in which they have to operate in the state. And for our existing medical operators, of which there are currently 10 that are operating, when they expand their number of stores, they have to expand first to unserved and underserved areas of the state. That's one. Two, the existing medical operators, as well as any new medical operators, have to make sure that they are competent to serve populations in unserved and underserved areas of the state. So we took on the task of then identifying unserved and underserved areas of the state. For short, I'll just say unserved and underserved. And this page here features an interactive map as well as a list of census tracts. Let's just scroll down a bit and I'll explain to you how we were able to identify these areas. So at the top here, this is reference to the cannabis law, which I mentioned, where it talks about the importance of these areas. And again, these medical operators have to demonstrate that they are culturally, linguistically, and medically competent to serve these areas. When we were thinking about how do we identify an area that's unserved and underserved, there was a lot of push from our health equity working group to make sure that the definition was human-centric, right? That we were not looking at, for example, the location of medical stores around the state, but rather that we were focusing on the people of the state and who needs medical services that they're not getting currently. So we identified a few variables. If you can just scroll down a bit, please. Thank you. We identified a few variables that helped us assess these areas. And we created a sort of health disadvantage coefficient or score that we were able to use. The variables we looked at are one, population to provider ratio, population greater than or equal to 65 years of age, the uninsured rate, low birth weight, premature deaths, household disability rate, and drive time to healthcare. We're essentially trying to figure out where are people the sickest with the least amount of medical resources. We then identified census tracts that have the highest rates, the highest scores or coefficients according to these variables. And we looked at what the characteristics of those census tracts are. So if you can just scroll back up to the top again, please. We'll see the interactive map. Sorry, it takes a little long because the server does the serving. But essentially here we have a map that shows what areas of the state we've identified as unserved and underserved. And again, these are the places that our new operators, as well as our old operators, have to target and have to prove that they are culturally, linguistically, and medically competent to serve. So that means everything from providing research opportunities, making sure they're doing community outreach, making sure they have community partners that they're working with. Now, very quickly, as this page loads, I'll turn to my final point here, which is the expansion of the medical program at large. As I mentioned, we currently have 11, we currently have 10 more, we currently have 10 operators in the state, and we are looking to expand that to more operators. These new operators that are coming on have to prioritize, have to demonstrate that they are within the public interest, that they can serve the public interest. So we're looking at things like, again, their cultural, linguistic, and medical competence. We're looking at how are they thinking about the environment? What's their environmental impact plan and environmental sustainability plan? Where are they trying to locate dispensaries? And are these dispensaries located within any of these purple census tracts here? These purple census tracts that you see in front of you are the ones that we've identified as unserved and underserved. And we really want to make sure that patients are able to access their medicine where they are, right? We know that one of the reasons that many people don't pursue this path of medical cannabis is just an access issue. And so it's easier to self-medicate and try and figure out your dosage and your strain, what works best for you on your own. But again, we are expanded the program to better support patients, and we're looking for operators that can do so. I know that I'm running over, so I'll stop right there. But thank you all, and thank you, Deborah, for providing the link in the chat if anyone wants to look at this further.
Thank you, Tabitha, for the in-depth discussion and presentation. Before we get into the question answers, we're going to next have a presentation by Jim Rogers. Jim Rogers is the Office of Cannabis Management's Director of Business Development. He's going to present on programming and its focus on the promoting the social equity within the cannabis industry. He's going to also review some training initiatives and support programs they have in place for those equity applicants, as well as discuss the importance of community engagement and inclusion in the cannabis industry. It's my honor to introduce Mr. Jim Rogers.
Thank you. Thank you very much. Good afternoon, everybody. Thanks so much for having me. I never like to go after Tabitha, but I'll try. I'm Jim Rogers. I'm the Director of Business Development here at OCM, and that is also part of the Social and Economic Equity team. In fact, all of sort of economic development, business development, access to opportunities is housed within the Social and Economic Equity team by deliberation. The statute provided for there are two positions at the Office of Cannabis Management that are provided by statute. One is the executive director, and the other is the chief equity officer. This is all by design. We don't want to have a market that emerges without direction. And people talk about fair markets or unhindered markets or natural markets, but none of that's actually true, right? I mean, what's true is without guidance, markets default to rewarding institutions and individuals who it's always rewarded, and it is self-perpetuating, which is the frustrating part about trying to both construct the market, construct the regulations, so that we are able to do what the statute says, which is to prioritize social and economic equity, and do so in a way that we haven't crossed any constitutional barriers, and so many constitutional barriers were crossed in constructing the market that favors existing institutions and individuals. But that was then, apparently, we're told, right? Now is now. So we're going to watch you all, meaning OCM and the state of New York, very closely to make sure you don't cross them, even though they've been nothing but crossed. So I should just say, just by way of background, I spent 10 years as a public defender in Bronx County. I primarily representing people accused of felony drug charges, arrested on felony drug cases, and taking those cases to trial and demonstrating the inequities built into the institution of policing in New York City. And those were winnable cases. And the idea that now we can fast forward and look at some of that damage and take a couple of steps forward to justice, right? None of this accounts for what Giuliani achieved in the 90s in terms of destroying communities. But it's some measure, it's using state resources to put justice in a market that would otherwise emerge unjustly. So yesterday, when the governor had a press conference, she said that among the things she was proud to announce was that New York State had doubled the number of Black and brown owned cannabis businesses nationwide. And that's true. We have done that. And we are not only an equity business state, but a small business state. So what does that mean? That means, making sure that markets left to their own devices, which favor easy access only to masses of capital, and there are no other metrics to choose winners and losers, don't dominate this market. And obviously people see we've had a lot of bumps in the road. So the MRTA says that 50% of licenses should go to what the statute defines as social and economic equity. We have far surpassed that. I believe it is nearing or over 70% of all of our licensees meet the social and economic equity definition, and we really have to pause there. okay? Because it was every other state, every other cannabis state is looking at us and saying, you know, they actually did it. Because if equity is an afterthought, it will never work. If equity is a program, it will never work. But achieving equity didn't mean that we were um, making preferences that were to some constitutionally suspicious. It actually meant something much simpler than that. It meant providing access, lowering barriers, informing people of opportunities, making sure those opportunities to buy into a license didn't cost more than the average person could afford. Um, and so just reducing barriers and by promoting opportunities for everybody and not making those licenses available to the highest bidder, um, that made our licensing pool reflect the actual demographic realities of New York State. I'm not saying mission accomplished, but you know, we have a long way to go. But I think it was unimaginable to anybody 2 years ago that we would get here. And believe me, you know, corporate cannabis tried to stop us. We've been sued tons of times. We've been shut down tons of times. But like, it didn't matter. Like, still, you know, there was perseverance. And like, how did that happen? Well, you know, people were hired into this agency based on ideals. Like, if they were mission driven, you're on the team. If they're not mission driven, you're not on the team. So I'll tell you the truth, you know, I've worked in government for a long time, but the subject matter I'm covering now is new to me. But what I cared about is who's going to get the license, and how are we going to get those licenses into the hands of equity applicants, and then how are we going to provide resources so they can succeed? And I know this is a conversation about health equity, and I want to say that I think all those issues are very much health equity. I mean, access to opportunity is very much health related, right? Freedom from discrimination and being prevented from getting an opportunity is very much health related. Living in a fair world and an access to an actual fair market is, I think, a health concern. And so if that's true, we really have to look at like markets as they exist without any without the hand of some sort of guiding principle and the kinds of principles that we follow at OCM. And we see that in our economy. We see who the winners and losers are. We see the rewards that sort of the cash rewards that came out of the COVID epidemic and the crisis that America went through. It just wasn't the same crisis for everybody. But it was a real great look into how the economy chooses winners and losers if left untouched by some guidance related to values and what we care about. So we avoided the pitfalls of other states, and you know, who wanted to make sure that there was a market first and equity second. We don't want a market that's not an equity market. We'd rather have no market at all. And that's tough politically because, you know, it takes more time. And now that we're really getting there and the market is, you will see, growing and growing, I think folks can finally say that we were on the right track all along. And so let me just talk real quick about programmatically, you know, what have we done? One of the first programs that we rolled out was a training and mentorship program that was designed to train experienced cultivators, and processors, both in traditional agriculture and food and beverage processing, as well as in what is called legacy or existing cannabis cultivation and processing, right? We're not introducing this plant to New York. There's been people growing it and processing it here for generations, and making sure that they were included was also another task that other states hadn't attempted. And what we wanted to do is say, look, if you're an experienced cultivator, cannabis cultivator, or you grow tomatoes, and you want to learn how to be in the regulated cannabis market, here's a program for you. And people went through that program, and because they participated in that program, we have a number of them that now have licenses, and more to come. So providing a bridge to people to say, bring us your experience as it is. Like, we're not telling you how to do it. First of all, you're telling us, and it was really funny in that program because we thought the information was going to come from the experts out to the mentees, and I'm really using a lot of air quotes here, but it was really, so much of the value was the other way. It was the mentees telling the so-called mentors how to do it and how it could be done. And the value added there was, what's it look like to operate in a regulated marketplace, and here's the boxes you have to check. And so now you are more ready. Another program that we rolled out and we are greatly expanding upon was a retail accelerator program. A business accelerator is a place where people who are heading imminently towards opening their doors can accelerate their readiness to succeed once those doors are open. And we had the largest and most successful, and we now will double or triple the size of that program. So for our equity licensees in retail, cannabis retail is a tough business. And people say, really? I mean, there's so much money. Like, look at all the millions of dollars changing hands. That's all true. But first of all, retail in general, if you know about it, tough business. Cannabis retail, really tough business because of federal prohibition also means federal tax consequences. So you can't deduct, you don't have the same kind of business deductions when you're starting a new business as you would if you were opening a shoe store, where everything is deductible such that you're paying like a net effective tax rate of 5% maybe. Because of the federal tax laws, none of that is deductible, and you're paying a net effective tax rate over 50%. So by the time you're done paying all of your expenses and paying Uncle Sam, profit is not easy in cannabis retail. There's some murmuring that that's going to change at the federal level, and I think you all know what the National Institutes of Health have said about descheduling cannabis. But let's see what the DEA says, right? The DEA has been its own thing for a long time, and nothing's going to happen until they agree. And whether they'll agree or not, we will see. Is there enough political will to do this statutorily? No. But there is, there is a path where the DEA agrees to a rescheduling, which will provide some ability to make this more profitable. So that retail accelerator program is so vital. What did people get in that program? They got initially 40 and now 60 in-depth workshops on every single thing that you could possibly need to know, and all the red flags that go with any single part of your business model. They got access to one-on-one mentorship. So they were connected to people who have either owned or managed a retail dispensary in another state. They were connected to people who were financial consultants who charged tens of thousands of dollars to come up and assist somebody in writing the pro formas that then businesses use to raise money. They could have that for free. Marketing consultants, where the fees are the same, also for free. And if you put all that together, you know, you have a very different kind of business in terms of its likelihood of success than you would have if we again leave the market to, you know, choose winners and losers. So that is another program. Looking forward, we are constructing now a in-depth, you know, where every economic region will have an in-depth cultivation incubator and processing incubator, which is both going to be a place to go and learn, but also a place to launch your business. Because as we said before, what the market's going to choose left untended to is people with tons of cash up front. And that's the only metric. But if you've got a great idea and you've got a ton of talent and you're really ready to go, but you don't have that sort of free access to cash, which isn't even real money, right? It's numbers on the page. And people who have access to those pages are not everybody. It's only a few people. Well, you don't have to worry about that in New York now, right? You can take your amazing idea, you could take your amazing craft, your amazing ability, and the business that you've built, and you can come to one of our incubators and launch it there. So your first couple of years of revenue you can now compete with the people that have access to all that cash up front. So that is another thing that we did and will continue to do is, you know, free application assistance, you know, to all equity applicants. So if you want to apply and you're intimidated by the process, and I know I am, here's somebody that will help you, walk you through it step by step. You know, as long as it takes, you have a person to walk you through that will continue. And I just want to flag the banking issue because access to cannabis banking is really a mirror in terms of access to banking services and capital, you know, in non-cannabis world. So I'm just flagging about that. I could go on and on to talk about that, and so I'll have to leave for next time the issues of what we're going to do about banking, which should solve banking problems outside of cannabis too, and what we're doing about workforce in terms of workforce training and access to those opportunities. So I think I've hit my time. I put my timer on, and I'll leave it there for now. Thank you.
No, thank you both. And thank you both for helping us explore the nexus of healthcare justice, cannabis equity, and equitable industry development through the restorative justice lens and unlocking the pathways you guys are unlocking to inclusion in this New York State's murder journey. I'm excited to dive into this discussion we're about to have and the questions. We'll start with some previously submitted questions that you all had submitted through Eventbrite. Again, if you do have any questions, the Q&A is open. You can submit those questions anonymously or not. The only people who will see those questions that you submit are the hosts and the speakers. And so this first question, you both touched on some initiatives and programs that OCM is currently working on to ensure that equity is in the cannabis industry. In the realm of public health and community support, addressing the specific needs of marginalized communities are pretty much paramount. And when we consider those initiatives to expand access to not only cannabis healthcare equitably, but also creating an equitable workforce from seed to sale to also ancillary businesses that will support the industry, it's crucial that we also ensure that these programs are tailored to those unique challenges of those communities, especially those purple communities that Tabitha showed us on the map. How can public health really contribute to the design of those initiatives, and how have they already been contributing to the design of those initiatives? And have you seen any successful implementation with public health institutions in other regions or other states?
Yeah, so I can answer that one. Again, my background is not in public health, so I'm only sharing what I've seen and what I've worked on. But one of the ways that I think public health can help us with these initiatives is by actually taking it to the public forum and actually making it a dialogue. I think oftentimes when we think about the role of government, especially in the health equity space, with the equity being dropped, it's very top down. It's very hierarchical. It's very much that government knows what's best and knows what the people need and what the people want. The model that we're going for here is one that is more collaborative than that, right? One that actually includes a dialogue between community and between us as the agency. We have an entire division, our external affairs team, that is our public-facing arm and does a lot of the work out in the community. A lot of the people who are on that team come from the Department of Health and come from a health equity background. And so making sure that we are out in the community talking to them about health outcomes, about challenges that they face in accessing healthcare, around debunking stigma, around really understanding the intersections of healthcare and everyday life. You know, health is not just something we do on the side. It sets the foundation for everything we do, right? We know that. Without health, there is no job, anything else, family, career, you know. And so what we're trying to do is create a stronger dialogue between ourselves and the community. When we look at other agencies, so we work a lot with other cannabis agencies around the country. And it's quite a collaborative environment. One of the things that we discuss with them a lot is on labeling and packaging, right? And thinking about the ways in which labeling and packaging is us communicating to the public around the health priorities of the agency. We received feedback from the community that the labeling and packaging rules we created were actually made it actually very difficult to understand what they should be looking for, and that there were ways to still achieve our goals of protecting consumers and protecting minors without being so restrictive in terms of market implementation. Right? So we were able to take that feedback, and we're revising our packaging and labeling rules to better manage and balance those needs.
Thank you for that. And I want to, maybe we can expand on that a little bit in terms of like the dialogue conversation, because you also talked about the importance of like education in your presentation. And when we think about having these dialogue in the communities that have been marginalized and that are underserved, it's also important that we acknowledge those barriers that are in place, and that also the challenges that may arise in having those conversations. How can we effectively start having that dialogue and addressing those education barriers and obstacles effectively to ensure that the success of these initiatives, because sometimes we may have these ideas for initiatives, but if we're not effectively addressing those barriers, the initiatives don't matter. So how do you all see effectively addressing those obstacles?
I think there are a number of ways here. One is in these communities that have been marginalized, I think we all need to see examples, right? Examples of marginalization being reconstructed and used as a way to signify success, right? We need to see some sort of path of success. So I think, for example, in our community dialogues, we've identified what's called communities disproportionately impacted. As one of our social and economic equity groups under the law. We have been able to meet with those communities and talk to them about what they want from cannabis, both in a medicinal sense, but also in an adult use sense. And one of the things that have come out of those meetings are actually, we don't believe you that it's legal, right? Which speaks to the trauma that these communities have faced, that even when the state is here with the state badge saying it's legal, they're like, it's not. The police will still come after me. And so I think one of the steps that we can take and we're trying to take is to elevate these communities disproportionately impacted, right? From having their defining characteristic not just being the fact that they were disproportionately impacted, right? But that their status, the conditions that they faced as a community disproportionately impacted, we call it CDI for short, is actually now an opportunity. And with that opportunity for licensure, with that opportunity for access, with that opportunity to be prioritized when we think about who owns businesses, where are these businesses located, how were these businesses supported, as Jim Rogers just described, that type of success story, I think is in and of itself a form of education, right? The good word always carries itself. And what we need to do is to make sure that the good word is being developed, accultured, and written by those communities. And I think they'll do a lot of the work for us once we support them.
And actually, let me just add on to that to tell you about something that Tabitha did that she forgot to tell you. So when she was writing the Social and Economic Equity Plan, which is this opus of all of our hopes and dreams of what's possible, she engineered sort of a community engagement plan that spanned months, talking to all of the communities, the social and economic equity communities mentioned in the statute. And what was new and different, because I'd been in government a long time, and she's new to government, it was like government usually like, here we are, we're telling you something, bye, right? Here's our message, bye. She spun that and did the opposite. She said, we have some questions. And every one of those sessions, there was somebody who would lead the discussion, just prompt, and then somebody there taking notes, verbatim notes. And then all of that feedback was actually categorized and measured. So then that could become, a quantifiable directions for the social and economic equity plan. Now, government's never done that before, and I don't care what anyone says, but it's never happened that way before, that we're there to listen. And then that listening, actually, you can read it in our policy documents exactly as it was told to us. I think that sets the tone for now how the agency handles engagement and what we expect out of that. We really don't need to go out and tell people what we're up to. We need to go ask people what we should be up to. And I think the first real effort at that I'd ever seen in government was her program, and it was, I thought, fantastically successful.
Thank you, Jim.
Yeah, that's pretty incredible. And like you said, like it doesn't happen a lot. So that's super, super important, especially when we're putting social and economic equity in the forefront. I think this question is a good follow-up to that question when we think about the community engagement plan you put in place, Tabitha. When we think about community engagement, involvement, and collaborations in that sense, how can collaborations and partnerships between healthcare providers, academic institutions, and Tabitha, I think you touched on this a bit in your presentation about some of the initiatives you all have been doing, community organizations, government partnerships, how can they be harnessed to really promote this equitable access for individuals, and contribute to also the sustainability of making sure that equity stays through and through the market?
No, that's a great question, Tamisha. And I think that the possibilities are endless, right? So it is partnership. It has to be at the core of it. And also accountability. We release regulations from time to time, as most state agencies do, and engagement around those regulations is huge. The regulations reflect what we, the agency, think that the market should look like, think how the various actors and players should be governing themselves. And we are constantly asking for individuals, groups, advocates of all natures to provide feedback on that, right? I think much of the public isn't aware of this notice and comment period, which usually lasts about 90 days and in other cases 45 days, but really engaging with us on that level, which means we post the draft regulations to the website, you read them, you send an email saying, I don't like this, I do like this, change this, and you can be as broad or as narrow as you want, but that sort of nitty-gritty feedback is key. And we go through every single one of them. And we amend our regulations based on the comments that we received. And by law, we have to respond to every comment. So even if we disagree with the feedback, we still have to respond to it. One, so I think it's engagement like that. Two, definitely partnerships, partnering with organizations that can help us do the training. We are a government agency that is limited in resources, right? We do not have an endless budget. We do not have all of the expertise in-house that we need to make this market work. And there are so many things that we wish we could do, but we can't legally do. And so it's great having these partners who can do a lot of that work, right? Who can sort of be places where OCM cannot be, who can make those points that OCM can't make. And so partnering with organizations for training, like I mentioned, is something that we're doing, on the ground, training practitioners who are going door to door and knocking to promote events around health equity and equity in the communities. Partners who are proposing research projects. That's another one. We have a research license, which is the first of its kind, and it's in the nation. It's not a project that I've worked on, but the health and safety team has done a phenomenal job at developing a research license. It is the first in the nation, and you do not need to be a professional, certified professor type of researcher, right, in order to have access to that license. You do not need to be connected with an academic institution in order to have access to that research license. And there are parameters around it that, things that you can do and cannot do with it. But again, the goal is to produce knowledge around this plant and take the knowledge that many of us have within our communities and give it a formal platform whereby it can be elevated and it can be shared with you getting your credit for having done that research. So that's another way that we're hoping to partner and work with other stakeholders here.
And actually, I would like to answer how can public health and OCM work together? With raising a topic that is going to be controversial, and so we don't expect to answer it now, but it's really a question for the public health community. And so the two premises, just to keep in mind as I pose the question, is destigmatization is a goal and way harder to achieve than I expected. Right. And the second goal is for every bar that serves alcohol that we can close and replace with a cannabis recreation place, something that we're going to ultimately call consumption lounge. I believe we will have well advanced the cause of public health. If we can start shutting down bars and start opening up other recreation facilities that are cannabis based, I think that's a major public health win. However, the feedback from the public health community is when it comes to combustible or vape related inhalation, that's a red line in public health. And I get it, because it was generations in the making, to get smoking out of our life. But without it, we're going to have a difficult time achieving destigmatization at the rate that we need to achieve it at, and at sort of beginning to de-emphasize alcohol and the obviously negative health effects of alcohol. And we can get there. And so it is a debate question I'm throwing in all of your laps to see if anybody wants to talk about, can you envision, as a public health person, a consumption lounge that permits a wide range of uses that 5 years ago you would have said no way, if the net public health outcome is worth it? And so the sub question is it worth it? And I have no idea, but I would love to have this conversation.
That's a really good question. And when you pose it, my public health brain went like environmental things, like when we think about like smoking in indoors at that, right?
Yeah.
But let me stay the course, as my brain is like,
Yeah. Well, next time.
But speaking of like stores, right, and the knowledge, a big piece, and regulations as well, right? A big piece in the elephant in the room, right, is when we go out, we look out our door, there are illicit shops all across the city. And a big piece of the illicit shops is really understanding regulations and what it means for those shops to be there, what not to be there, what's legal, what's not legal. And of course, when we think about these underserved and marginalized communities, sometimes understanding regulation and policy can be a little bit difficult. And so how is OCM working with stores or with those individuals in those underserved communities who may have not taken the right steps due to confusion and not really understanding the policy environment and what really that social and economic equity meant? With the paperwork and different requirements, are there any programs that are specifically for those communities and assisting to them really understanding the policy and what that really means?
So the question is outreach to people who are unlicensed but selling the product to sort of help them move towards.
The legal space.
That is a really good question. I mean, it's funny because, and I'm really glad you posed the question, because we have been thinking about the unlicensed issue because it's in the forefront of everyone's mind, in a much more binary way, which is like, we need the licensed shops to succeed, and to do so, the unlicensed shops have to go away. And I think we've very much approached it in a black and white, good guy, bad guy mode, which is, partially because that people haven't thought more deeply about it, and partially because um for efficiency's sake, we've got to do that. But your proposal that, what about approaching those stakeholders, because they are,
Right.
in a way that assists them in a transition? um I think that is a really important idea that needs to be, part of our conversation. We are really focused on shutting them down. And I'm not in charge of enforcement, so I can't say what they've thought through and what they haven't thought through, but I would certainly put that on the desk of those folks and say, let's see. Let's see if we can approach some of the problems that way. So I appreciate you raising it. I have an unsatisfactory answer.
No, it's okay. It was a participant question, and it's a good question, right? Because I think when we think about when people hear social and economic equity and it's prioritizing those communities that have been underserved, then it's like, but not really understanding the nuances that come with that, right? And the understanding of how to really build out a legal entity in this industry. In addition to that, do you all have any veteran demographics in underserved areas? Have there been any past or current research with that in OCM?
Sorry, can you be more specific?
So when we think about a part of the social and economic plan and equity, not only includes veterans, right? And so has there been in that demographic, the map you showed, has there been research to really identify the veterans in that space as well as like those marginalized communities, and not just based on like race, but also based on like military status?
That's a great question. So in the map that I showed, no, we did not look at the veteran community, as we were trying to focus on variables with a direct relationship to healthcare outcomes. Now, with that said, one of our social and economic equity groups are service disabled veterans, and we do engage a lot with that community. When Jim was mentioning the programming, community engagement programming that I spearheaded, we met with veterans around the state, downstate as well as upstate, and we heard very interesting things from both, and I think a lot of us were surprised around learning the various facets of the relationships that the veteran community has to cannabis. We had not thought, let me speak for myself, I had not thought about the veteran community as being a large, as having large potential for becoming patients, right? I had not thought about the intersections between the veteran community and health equity specifically, and the ways in which they use cannabis or hope to engage with cannabis, not just for business opportunities, because we know our vets are really good at operations, but for their own personal and medicinal use. And one of the things that came out in those discussions was, I don't want a business. I don't want to be an employee. I want to be able to access my medicine. And how can you help me access that medicine? Now, because the veteran world is at the top, it's a federal world, right? There are certain things that we can't touch, can't deal with. For example, the ways in which their consumption or involvement within the cannabis industry might affect their status with the federal government. That we can't touch. But from a state perspective, we are very much thinking about the ways in which there are public health and health equity opportunities within the veteran community. So that includes identifying what conditions they tend to face the most, right? What health issues they struggle with the most, and making sure that in our medical program, we have direct pathways for those kind of conditions, right? That also includes how do we make sure that our product is at a price point that a lot of veterans can afford. We know that a veteran span, of course, an entire socioeconomic scale, and many of the ones who are seeking medicine are also coming with economic barriers to entry, right? To enter this market as a consumer. And so how do we make sure that we are meeting them where they are from a condition standpoint, but also from an affordable product standpoint, so that, again, they are preferring to self-identify as patients rather than going to the recreational market and self-medicating there.
Nice, thank you. Jim, this may be a question for you. Let me see how I want to pose it. So when we talk a lot about the cannabis industry and the cannabis space, a lot of the conversation and the jobs have been around dispensaries, but understanding this is a big industry and it's more than just dispensaries and bud tending. How is OCM ensuring that those CDI communities receive also equitable access to spaces like processing, licensing, also those ancillary services, like who's helping building out this cannabis space and this cannabis industry? Are there measures you all are taking to ensure that that's also representative of those CDI communities?
Yeah, I mean that is a great question. And when we were first framing out, you know, certain on-site, on-farm cultivation, mentorship, and training opportunities, and we were thinking about, okay, how am I getting folks from Brooklyn to the closest farming
Right.
community in a sustainable way? You know, we understood that that's, you know, not possible, but there have been cultivators in the urban setting for this plant, obviously, for generations and generations, and so there is, you know, as far as our upcoming incubation opportunities, which are going to be both a place to learn and a place to start your business, are going to cover both outdoor grow and indoor grow. And for indoor grow, those will be readily accessible. But for outdoor grow, we're going to build into our understanding of the costs of a meaningful training incubator program, room and board, right? You know, so that you know, geography shouldn't be the thing that limits you. You know, do folks want to go upstate New York and live in a farming community and learn the outdoor grow? You know, I think yes, actually, a lot of people will, because it's really attractive, and you hear about, you know, young farmers, you know, all the time, and there's a new generation of you know, craft farming, you know, all throughout any kind of fruit, any kind of vegetables, and young people and so I don't think it's at the forefront of everyone's mind that this is a possibility, but we'd like to make it so. And I think when that incubation program will have enough room in it, and it'll be significantly funded by the state, so people have their choice to do it. And right now it's not on the table at all. unless you know someone who knows someone who knows someone, you know, you're not going to be able to learn on a farm coming from a city. With the exception of Rochester, which is really sort of Finger Lakes Community College has done a great job in the cannabis space of, you know, a great curriculum and really engaging people who come from the city of Rochester in the idea of hands-on outdoor cultivation across the board. So they've got a lot of working models there now. But yeah, we want to do both. And the supply chain is really interesting throughout, you know, not just cultivation, processing is its whole thing. So our incubation facility is going to have, you know, multi-million-dollar processing equipment. And then there's low-tech processing. There's people that make things to consume. And that will be both, you know, urban, suburban, and rural. So we think that we have to promote the opportunities, you know, and not think about who it is that takes, you know, advantage of certain not make assumptions about what we think people want. Again, back to like, let's ask, you know,
Yeah,
how
that
many
really
people in this room, right? How many people in
right.
this room are interested in you know, living on a farm in the middle of nowhere for a year and learning this craft from the ground up, and the state will pay for it. Who wants to do it? And I think we'll get takers.
Definitely. I think you guys will as well. And I think to expand on that question, Tabitha, you touched on just like the overall, with the expansion of the medical program and the new requirements for your ROs to exist in those communities that have been underserved. Are there any, and when we think about getting into the medical cannabis space, it is a bit pricey, a little bit more pricey than we think about recreational. Are there any programs or initiatives or financial incentives for those people who may be from those CDI communities to get into that space, who maybe not have the access to the kind of capital you really need to get into the medical industry?
Yeah, that's a great question. And it's feedback that we do receive from time to time. The application to become a registered organization, which is our medical operators, the application fee was about $10,000. Comparatively, the application fee for our adult use program was only $1,000. And that was discounted 50% if you qualified as social and economic equity. So big price difference between the two. And the price difference is really because we are recognizing the difference in these markets. And we're recognizing where each of those markets are. So in the adult use market, we are starting it from scratch, right? So it's easier for us to sort of create the criteria of what the operators will look like. In the current in the medical market, which is pre-existing, there have already been 10 operators, and these 10 operators are multi-state operators, very well capitalized. Many of them are publicly traded. I believe most of them are actually publicly traded. And so we set the application fee at $10,000, which is a lot comparatively, but compared to most other states, in most other states, the adult use application fee is about $20K.
Yeah.
Right. So we see ourselves as still below our peer states in terms of the barrier to entry. However, it was important to recognize that the existing medical market, because it has these operators who already are well capitalized, that we had to allow new operators to be able to compete. And one of those layers of competitions means that they don't have to be as well, you know, capitalized as the existing players. They don't have to be publicly traded by any means, but we do want them to enter the market and to stay here, right? We want them to be able to perform neck and neck with the existing operators if they are to have a chance. Now, with that said, we are providing supports to those operators, to those new operators. One of the ways in which we are looking to move away from the existing model is by prioritizing what's in the public interest, right? And so what's in the public interest is a new thing on the table. And it looks not just at how how much money they have, because that's the least of it, right? But really, what is their goal for the state? How are you in the public interest? How is it in the public interest of New York State for you to get this permission to operate? So as I mentioned earlier, tell me what you care about the environment. Tell me how you care about diversity, equity, and inclusion within your organization. Tell me that that's a priority. Tell us that you have a plan to make products affordable. So we are not looking to repeat what's already been done. We are addressing the new needs of where the state is now. Lastly, I'll say it's important to recognize that where the state was when the medical program first launched, as I mentioned, was very risk adverse. Cannabis was, the big great devil, and we sort of moved away from that. But that move has been incremental. And so what we envisioned for the medical market 5 years down the line isn't even where we are right now. We hope to get to the place in the medical market where, rather than requiring that all of the companies be vertically integrated, as is the requirement now, again, to compete with the existing players, we hope that we can issue registrations for medical operators that just want to do dispensing. You are a dispensing only medical operator. You don't also have to grow your product. You don't also have to process your product. You don't also have to distribute it, which is the case now, but you just want to focus on patients come in your door and you give them quality product. So those are longer term models that we are building towards. But again, our goal right now is to make sure that given the market that we have, we can expand it in a way that considers health equity, and that those players are able to actually stay and win. And then once that is sort of built out in a more equitable framework, we look for other avenues to bring in equity and lower the barriers.
Nice. Those models do sound really pretty lucrative. And we talked a lot about New York State and how you all have set up this industry to be socially and economically equitable. Accountability is a huge key in promoting equity and making sure that it's sustainable in this industry and in this space. What specific measures can be implemented or are already being implemented to hold all stakeholders from top down accountable for the contributions toward the goals and ensuring that the meaningful process is sustained? You're
And Tabitha can elaborate, but I'll just flag, the TPI, the investment rules, the true party of interest rules about how much you can own of how many licenses and the significant limits that there are. And so, what happens in the predatory space is that, a social and economic owner is makes a bad deal. And that bad deal ends up losing control of that equity owned business. Once again, capital sort of takes over. But with the systems that were built to track investors across license types, and so we have an understanding of how much of this industry do you own, because we're only going to allow you to own so much. Another part of the architecture that Tabitha created, that we can watch in a very unique way how money is moving, in this market. And it's really the ways in which capital has taken businesses away from their rightful owners because of these predatory deals that are really difficult to catch, really difficult to track. The people that perpetuate that kind of business practices, they've been at it for years and years. They know how to do it. But we think with the way that we track investment, that there's a lot of safeguards to make sure that equity businesses remain in equity hands. And I think how we enforce our rules, we'll have to see. We got plans, we got ideas, but we got to do it. We have the best rules in the country to protect the value of the equity license in the hand of the equity owner. But, policing these big money players is tough. Ask the SEC and ask, and ask FINRA and ask any of the regulators on Wall Street, and they'll tell you we catch 2%, of the cheaters. So we need to catch most of the cheaters to be effective. So the structure is there, but we got to make good on it.
All right, thank you. And as we, I'm getting the timer. I'm going to end with this because there's a question about social equity applicants. And so I want to make sure people are leaving with the understanding of the differences and understanding what the difference is with social equity in the recreational space and the difference in medical space. And so the question asked about medical cannabis licensing and awarding to those social equity applicants. So can you all, I think, make sure kind of leave with the understanding of like, who are the social equity applicants and how do they exist in both spaces, recreational as well as medicinal?
You want to take that one, Tabitha?
Sure. The adult use program has social and economic equity applicants. There are essentially 5 to 6 groups: service disabled veterans, distressed farmers, minority-owned businesses, women-owned businesses, individuals from communities disproportionately impacted. And then there's an extra priority group, which includes people who meet 3 criteria. First, they're from a community disproportionately impacted. They themselves have a conviction, or they are a close relative of someone with a marijuana conviction, and they fall below a certain income within their county. Those are the groups that are social and economic equity. That is on the adult use side. On the medical side, we are not talking about social and economic equity applicants. And I'll also just weave in an answer to Deborah's question posed in the chat, which is the application window for our medical operators just closed in December. We're currently reviewing those applications now. So I can't tell you how many have been issued because they haven't been issued yet. That is medical. So you apply for medical, totally different company than the ones that apply for adult use. The adult use applications are where the social and economic equity groups that I just named, the 6 of them, live. As part of their application, they were afforded 50% reduction in fees. And depending on what group they received priority in prioritization and consideration of licensure and the type of technical assistance that Jim described earlier on their applications. But they are very much 2 different worlds.
Thank you. Thank you both for this discussion, your presentations. It was super, super helpful and impactful to the discussions we've been having. And I'm going to end our Q&A session here. Did you all have any final thoughts you wanted to leave the audience with? We'll be sure to share all the links that Tabitha and Jim shared with you all in the follow-up email as well. Did you all have any final feedback before we close it out?
No, I just want to say thank you for the opportunity. We have a mailing list. It would be great if anyone wants to continue engaging with the agency to sign up for the email list. We send out a lot of blasts, including around our Cannabis Control Board meetings, which are usually monthly, our cannabis advisory meetings, which are usually quarterly, and any other press documentation or announcement of events that we have going out. It's the best way to engage with us for sure.
And the only thing I'll say is that the statute provides for a community reinvestment fund, which is a fund derived from the taxes on the product. The fund this year is $5 million in our inaugural year, but as a regular thing, it's going to be closer to $100 million as things really get up and running. And this is money that is, earmarked to go back in to the communities most impacted by the war on drugs and the CDIs that we've been discussing. And I would love to hear going forward, I could throw my email into the chat. Ideas that public health community has for how that money should be spent. We would love to hear it. You'll see in the coming weeks and months opportunities to, officially take in your suggestions. But for this meeting, I wanted people to know that let us know what you think about not just this year, but as an ongoing thing, how cannabis revenue can impact public health in a positive way.
Thank you both for your time. And thank you all for attending. As we are closing out, a poll will be coming up on your screens again. Please let us know your thoughts on the programming and what you'd like to see next. Maybe a program about the Community Reinvestment Fund and a Q&A that we could have. Thank you also to our partners for making this all possible. In addition, the Office of Cannabis Management, they're also on a current tour to discuss the Cannabis as Medicine in Your program, as well as the Budding Opportunities tour I want to see you guys are on as well. We'll put all of that information in the follow-up email. Please also visit their website, visit our website. For more information, we'll place the links again in the follow-up email of the webinar. Thank you all for coming and joining us for this last installment. Hope you guys have a great rest of your week.
Thank you, everyone.
Thank you.
Bye.